Most people are not going to pass away from the plane dropping out the sky or being run over by a train. Most people are going to pass away from a serious illness or some type of disease. So we have to prepare for that.
In the black church, we talk about death, we talk about the here and now, going to heaven, going where Jesus is, but when it's time to do that, nobody wants to go.
In the black community, as far as talking about death, it's taboo.
One of our myths is if you talk about dying, you're going to make it happen sooner.
En la comunidad hispana, la etapa, digamos, como final de la vida o cuando ya tú vas a pasar a la otra vida es un tema tabú, es un tema con mucho miedo, que no se habla en las familias.
El final de la vida muchas veces lo vemos como lo más triste y no debe de ser eso. Es un proceso que todo mundo debemos de tener en la vida.
What we know is that end-of-life care, serious illness care, and having those difficult conversations are not taught.
It's not about death alone. It's about family and bringing together, making people comfortable so they don't have to be scared.
Reach out to say, I have a loved one, and because you can't do it all by yourself.
It's an act of love to have those conversations, to be prepared, to make sure that our families are prepared.
Most people just don't want to talk about it.
An act of love. Talking with your family about serious illness and end of life. Every year, organizations dealing with serious illness and end of life find creative and beautiful ways to honor loved ones who have died in their care. Until this generation, most Americans lived and died in the same ways, from unexpected illness, accidents, and untreated infections. Life expectancy was short. In the early part of the 20th century, the healthiest life only lasted 50 years. But with the advancement of science and technology after World War II, the experiences of serious illness and death have been transformed. Today, more immediate diagnoses and treatment have resulted in longer life expectancy and a rising need for planning and discussion of care. In 2025, in North Carolina, some 81% of individuals aged 65 or older are living with one or more chronic diseases. These numbers will be growing in years to come, with a projection that 7 out of 10 people will require long-term care services in their lifetime.
So when we look at the trajectory of illness, it actually starts at chronic disease. And a chronic disease is any disease or illness that's greater than 6 months.
Chronic illnesses include heart disease, cancer, kidney disease, COPD, and other lung diseases, and diabetes.
We move from a chronic illness to a serious illness. So if we're using the example of diabetes, diabetes is a chronic illness. But when that patient progresses and that patient has had multiple hospitalizations due to vascular disease and they have necrosis where they're thinking about amputation, kidneys have been hit, eyes have been affected, so now that patient is now seeing ophthalmology. That patient has now moved from chronic to serious because there's more interaction with different providers. We have that same patient that is now has already had the amputation, thinking about a second amputation. They've had multiple hospitalizations. Now you have that same patient has moved from chronic to serious. Now we're in terminal.
Terminal illness means there is no known cure. Doctors are often hesitant to talk about how long it might last, but the expected outcome is death.
The question is, so what happens? What do we need to do?
The terms palliative care and hospice care are often misunderstood.
Home health, palliative care, hospice sort of shows the continuum of the care.
And palliative care is another form of medical care. It involves symptom management, it involves advanced care planning, it involves increased quality of life for that patient that's in that serious illness phase.
Palliative care, the patient has the best of both. They're able to pursue curative therapy and get supportive care at the same time.
The patients can continue to see their physicians, they can continue to do what they do. It's just another set of eyes, another part of the medical plan when that patient is now in that serious illness phase.
So when that referral is made for palliative care, then that provider, it's usually a nurse practitioner these days, which is great, they're able to go into that patient's home, review their meds with them, but the patient may be experiencing some very uncomfortable symptoms, such as pain, shortness of breath, or anxiety. And palliative care allows for that person to get a provider to come to their home. They're not ready for hospice yet, but they need some help at home.
And then when that patient transitions into the terminal phase, we move from palliative care to hospice care.
So when that patient now is no longer responding to treatment, nothing's working, the disease is still spreading, and the patient's getting more fragile. And now the physician feels it is the appropriate time for hospice. And the family is like, we don't want any more treatment. Now everybody's on the same page. It's the right time for hospice.
The right time to choose hospice care came for Crystal Carroll as she cared for her mother at home in Raleigh for almost 6 years.
It was a lot to go through. The very beginning, she was fine. As she started to decline, I was unable to help move her, feed her. She didn't want to eat. She had a small stroke in between. But we cared for her, myself, my teenage son, who was 16 when she passed, so 10 when we started. We took good care of her up until the last 4 months. I just couldn't do it anymore, and that's when hospice really came into play.
I think people don't understand how overwhelming being a caregiver is when you give your all 24/7.
Hospice helped. They sat down with me and said, these are the things you need to consider. This is, I had never heard of a DNR. I'm like, what is that? And so they explained it, and here's your paperwork. It's just the small things that people need to hear about.
Sometimes there's a visit from the social worker who would be what I would call a key member that could work either side. Or the chaplain may visit.
They're good at guiding you when they come in and look at your family member or whomever it is. And you can ask them a question and they'll honestly tell you, this is kind of what I see. Be prepared for this. Make sure you call us first. If you even need to call an ambulance, call us first. So they can kind of walk and guide you through it. You need that.
That obviously is one of the biggest situations you could ever be thrown in, to have a loved one go to hospice. And my mom, she passed away 8 years ago. We lived in poverty, I'm going to be honest. And you don't hear about those services. There just wasn't any education on what hospice was, what palliative care was. And I was scared of, okay, well, hospice is final. And if I put her on hospice, that's it. And I felt like I kept her here longer than she wanted to, because I was taking her to the doctors. Okay, well, if we go to one more doctor, and then she finally just said enough is enough.
There are many reasons that people do not trust the medical community or hospice.
When people of color hear hospice, the first thing we think is, oh, mama died. If we put mama in hospice, she gonna be dead in 2 weeks.
less than 10% of African Americans utilize hospice care in general. And so that's not a good thing.
People will say to us that, if you get on hospice, you're going to die right away. You get on hospice, they're going to give you that morphine and they're going to kill you.
And so when you say the word hospice, immediately people say, oh, they don't have long to live. They're getting ready to die. But that's not necessarily true. There are people who have been on hospice for a year and come off of hospice. Jimmy Carter, prime example, went on hospice and was on it for over a year. So sometimes it's just where you are medically that the doctors may say you may need hospice care. And that's for the family to be able to have people to come in and, give a bath once a week, for you to be able to get services that you probably would not be able to afford on your own. I mean, because it's covered by Medicare and Medicaid.
And I think the Black community, a lot of times we don't have the help that we need because we have our certain fears that we have.
También está la dificultad de no querer ir al doctor. No quieres revisarte porque tienes miedo de que te van a encontrar, que te vas a morir.
People are a bit leery when it comes to going to the medical, particularly if it is something that's chronic. You're dying, there's nothing else I can do. We sometimes wonder if that is actually the truth, or you're not willing to put the time in that's necessary for me to live my best life.
Y más cuando la persona es indocumentada, porque piensan que por su estatus no tienen ayuda.
I think we're much more trusting of the spiritual than we are the medical. And of course, there are historical reasons for that. When you think about the Tuskegee experiment, when you think about eugenics, when you think about there's not many people who look like us who come in the room with white coats.
And oftentimes African American families and also Hispanic families are strong Christian faith-centered. So they don't make decisions outside of what their faith is. They are going to consider that. They're going to tell the doctor, I'm praying for you, doctor, to make the right decisions about my care.
My aunt received a diagnosis that she had liver cancer. And of course, we are a people of faith. And so we were all prayerful and just very hopeful that she would improve, that her treatment would work, and that she'd continue to be with us for as long as was allowed. But it wasn't the case. And I'm really proud of my cousins and her husband because they embraced hospice. Faith oftentimes will propel people to look in a more positive light, and you want to speak towards the future, and you kind of feel like if you state things that are contrary to life, that you're essentially having a failure of your faith.
It's really important for them to consider, is this God's will? And often the issue of miracles comes up, because they've seen some miracles. So they don't discount that a miracle could still happen, even though they're getting this information from the health professional that the time is limited.
There is a song that comes to mind. One glad morning, when this life is over, I'll fly away.
And I think you die well when your affairs are in order.
In my role as a nurse, and I'm also a person of faith, I'm an elder in my church, so I understand the faith perspective. I understand my perspective as an end-of-life care nurse and advocate. We can't separate who we are. It makes sense to a person of faith that, well, it's okay for me to be having this conversation. I don't have to be afraid. Even Jesus had an advance directive.
If your congregation is over 75 years old,
In Raleigh, Transitions Life Care is bringing church leaders from around the triangle together to talk about serious illness and end-of-life care in a curriculum called Creating an Unbroken Circle of Care in Your Faith Community.
how did you feel?
These sessions stimulate conversations that people take back to their congregations.
It is crucial that we start at an early stage, and that stage does not have to be when people become ill.
I get calls at 11:30 at night where people are actually in a panic.
There's many tools and resources available to get people to at least start the conversation.
Just one simple phrase on each card.
We have a card game called the Go Wish game that is utilized to help facilitate those conversations in a non-threatening way.
We have the cards, we have the 5 wishes, and it's ABC. You sit, you talk with your family member, your friends, or whoever you're helping, and you can tell them exactly what you want.
The 5 Wishes booklet is also a document that families can walk through, and it gives them the opportunity to think about what matters to them, not just things related to who's going to be your healthcare agent or healthcare proxy, what you want done in terms of, CPR, do not do CPR.
I do want to be resuscitated, I don't. How long they would want to stay on life support. And I found out here that people actually do plan, okay, I want to be by the ocean. And, so you say specifically what it is you want, and it's in writing. And it doesn't get much easier than that.
Primero que todo nos preocupamos que sea un lugar íntimo para que las personas efectivamente puedan decir lo que sienten. En estas reuniones nos volvemos amigos y compañeros de las personas que están ahí, y en esta conversación ellos se abren mucho. Ellos comienzan a contarnos todo lo que no han conversado con nadie, ni con sus familias, ni con sus amigos, incluso con ellos mismos, porque es un tema que se va cerrando.
But our job is really to begin to get our families to have conversations first. What do I want? Like, my mom was ahead of her time with this. Like, she was the one who initiated the conversation, not her physician. She said to me, don't put all the money in the ground. She said to me, I want you to take care of your sisters. She said, this is what I want to wear, and I want to go home, right? And so those are the conversations that we need. So even if you don't get a piece of paper that is the advance directive, that family member, when there's a medical crisis, is not caught off guard.
And oftentimes we have those off conversations that says, I don't want to do what Aunt Jane did, or I don't want to go through that, And so at that moment, then it needs to further the conversation. Let's expand that conversation. So that can be one way, is to use our families, loved ones, church members' experiences to identify, do I want to go through that? Or it can be the other side. Oh, she had everything in place. Her children didn't have to worry about anything.
Yo soy sobreviviente de cáncer. Sé lo que es este proceso. Sé lo que tenemos que estar preparados. Yo en algún momento de mi vida tuve que tener este tipo de conversación con mis hijos. Y es algo muy difícil, muy duro, pero es necesario.
Transitions Life Care has been serving North Carolina families since 1979. Their staff and volunteers have assisted thousands of families wherever they are in the emotional and physical challenges of serious illness and end of life.
I have a background in training in ministry, and I had worked as a chaplain at one of the local hospitals. I had very little knowledge about hospice until I started volunteering. You know, the patient has a nurse, a CNA, a doctor, or a nurse practitioner, a social worker, a spiritual care counselor. It's a way of tying up the loose ends so you can let go.
The Transitions Hospice Home has 3 levels of care. In addition to round-the-clock care, they offer services like pet therapy and grief counseling for families, including children.
Well, welcome everybody to our time of remembrance. Thanks for your patience.
On this Tuesday morning, staff and volunteers at Transitions are gathered to remember those who have passed in their care.
We remember Emma and Olivia.
This is very much a more personal way of taking that journey through end of life.
One of the most sacred times in the hospice home is when someone passes. Staff and volunteers stop what they're doing and stand in honor.
The place has a peaceful energy. The people are peaceful.
That is one of the most sacred spaces that you can be in, is to experience the moment.
2 times I know that God is in the room. And that's when a baby is coming in and somebody's going out. How awesome is it to be in the presence of God? It's funny, I had a client and I was trying to, I talked to her about her process. And she said, I want you to sing me out of this house and sing me out of the church. And I said, okay. And she said, whatever you feel is the best thing to fit is what I want you to sing. So we didn't decide on a song. And I said, well, whatever God gives me in that moment, that's what I'll do. And so when I came that morning and found her, she was gone. I was able to wash her body, change her clothes, have her as if she was just sleeping when her family came in. And when they came to take her body and go out of the house, immediately, never thought about it. This may be the last time. This may be the last time, children. This may be the last time. May be the last time. I don't know. It may be the last time we sing together. May be the last time. I don't know. This may be the last time. This may be the last time, children. This may be the last time. May be the last time. I don't know.
Death is a beautiful transition when we have prepared for it.
Let's start to just have a conversation.
Don't be scared to have that talk with your loved one. In the end days, you want your family to be comfortable and you want to be together.
And it needs to be discussed, not what they're going to leave you when they pass, but how you're going to leave them. You know, they need your support.
Ask about palliative care, ask about hospice. Open your heart, open your mind.
I'll submit the challenge to volunteer. Volunteer and see what it's like to really help someone to honor their life and to add to the comfort that they feel in their final days.
Se tiene que tocar, se tiene que hablar, porque va a llegar un momento que todos vamos a pasar por un proceso de duelo.
We live every day. You only die once. So we need to make sure that the things we only get to do once in life, that we do it well and we're prepared for it.
Oh, some glad morning, come on, when this life is over.